Hello, my name is David James, and I serve as the co-chair for UAB's Safe Mobility Oversight Team. And with this presentation, I'd like to zero in and highlight the why safe mobility is so important and the case for change in our current practice. So with that, let's get started. So I'll frame today's presentation with the IHI Age-Friendly Initiative. So UAB is an age-friendly designated hospital. The Age-Friendly Health System Initiative was designed to equip hospitals and healthcare systems to care for the aging population, focus on evidence-based practice and aligning care with what matters to patients. The age-friendly framework uses the 4Ms model. So we always start with what matters to the patient. Then we think about medication safety. How do we ensure the medications we give do not interfere with what matters, mobility and mentation? Focusing on mentation by addressing the 3Ds, delirium, dementia, and depression, and mobility, ensuring patients move safely every day. So today I'd like to highlight how UAB is working to address safe mobility for these vulnerable patient population. So what do we know about safe mobility? Why are we focusing here? So we know back in the 1940s, Dr. Dock published an article in JAMA that said the bed is not your friend. By the 1980s, we had done research and really understood why the bed was not our friend. We had documentation and data supporting, blood clots and muscle weakness and all the things we know. By the 2000s, we connected this to our silver tsunami or aging population. And we know the bed is not your friend. We know bad things happen. And we know that if you're an older adult specifically, the outcomes can be even worse. And by the 2010s, we started to connect this to not only what's happened inside the hospital, but also post-discharge or pre-hospitalization. So the idea that I use a lot in my practice is the idea of post-hospital syndrome, which is the concept that there's a period of transient vulnerability when patients leave the hospital where they're more likely to bounce back to the hospital or require additional care. So when we focus on safe mobility, we reduce the amount of deterioration that patients may have, then we also reduce this period of vulnerability. So what's the gap? Well, we know that in the hospitalized patients, that patients spend a vast majority of time in bed. And the vast majority of patients are actually able to get out of bed, but we don't create a space for that. So when we think about our older adults specifically, 1/3 of hospitalized older adults will leave the hospital with more disability when they were admitted. And that is because we don't promote safe mobility and create space for safe mobility. So we know that that lack of mobility does have serious implications for our patients. So virtually every body system is impacted by immobility. We think about increased risk of pneumonia from aspiration. We think about GI slowing down and constipation and ileuses. We have muscle weakness, increased depression, anxiety, skin ulcers, skin tears, as well as increased workload for the heart. So by knowing that these things can occur, then how do we focus on safe mobility at UAB? So at UAB, our solution is to think about safe mobility as who and what is needed to safely mobilize the patient. So we think about patients in buckets. And so the first bucket would be patients that just need some socialization or encouragement. These are patients that are up at lib, no oxygen, maybe they have one simple IV line, RN's okay with them walking. So a family member or volunteer could easily work with this patient. Our second bucket of patients would be patients that need a little bit of assistance. Maybe they're a low or medium fall risk. Maybe they have up to 6 liters of oxygen, or they have a chest tube, or they have some kind of drains. The RN's okay for them to walk with someone, but it needs to be someone with a little bit more training and expertise. So this would be our patient care technicians or our mobility tech would be appropriate to walk with this patient independently. And then there's those patients that the RN needs to be with the patient, and they're with the patient for safety. So it's the very first time the patient's getting up, or maybe it's the patient who has invasive lines or clinically unstable. So the RN's with the patient, the family member or tech might be assisting, but the RN's making sure the patient's safety needs are being addressed. And then in our model, we have OT and PT, acute therapy, who serve as coaches and consultants to help everyone get to their top of practice. So if you're working with a patient, you're not quite sure how to use this equipment, or you're not quite sure what to do about these hip precautions, then the therapist can help coach us to make sure we're all at our top of practice. So with that, I'm going to thank you for your time. In our next couple of videos, we'll be talking about setting goals as well as some best practice strategies.